again on the same day or wait for a day and do it on the next day. This is another patient, very interesting patient, 40-year-old male patient had an AC iris chlophakic IOL, a nanophthalmic eye that was done 12 years back. After 1 year, severe inflammation, so explanted. And now for cataract surgery, IOL power is 36 diopters because the cornea was steep, so power came down, and axial length is 17.5. Always do the capsulotomy through the side port. Most important thing, don't lose your chamber, then you will have radial extension. And please remember, in all these eyes, always never direct the fluid under the iris, then you will have repeated iris prolapse and you will mess up. Use a Kellman's bent tip if you have, so that you will not distort the cornea while reaching the nucleus, so that your visibility is good during surgery, and always close the wound. So once again here the pupil has been, the Seneca release, pupil has been dilated with iris hooks, and then injecting the lens with the tip opened up like a crocodile's mouth or a beak, and the beak open so that the surface doesn't get damaged. This is of course under OVD. The IOL related issues include inaccuracy of IOL available IOL formulas, the spherical aberration involved in a large, very thick lens, the unavailability of high powered IOLs. Of course, now IOCare has started making customized IOLs for you, and the need for a piggyback or a bioptic or using contact lens or glasses for residual power. Next, let us look at post-angle closure glaucoma. This is one eye, AC is 1.3 millimeters. Post-acute angle closure glaucoma. Not able to reach the anterior chamber and do it without hurting the endothelium. So, trocar 25 gauge vitrectomy. Under irrigation from the anterior chamber, minimum vitreous is removed till the AC is deep under the fluid. And then you do it, then it becomes like a regular cataract surgery. And please don't forget to put one more peripheral iodectomy. Induced cataract in a hypermetropic eye, almost touching. So here, what I do is I put multiple punctures, a can opener in the center, so that you have multiple radial extensions, so that your intralendicular pressure is distributed along all these lines, so none of them will reach the periphery. And then you go in and massage, aspirate out all the anterior cortex, and then you go with your, now you can, once the bag is decompressed, you can go with your Uttaradas forceps through the main wound also, and there is no issue, and do your axis, and that is it. So in a crowded eyes, beware of potential complications. Phaco is far safer than SICS in a nanophthalmic eye. Always get an informed consent, and always stick to basic scientific principles. And with that, I think I'll stop. Thank you so much.
Thank you, JP sir, for that excellent and detailed video presentation. Now I invite Dr. Jason sir. He will be talking about idiopathic floppy iris syndrome. He is the consultant cataract surgeon at Jyothis Eye Care Hospital, Kannur.
Good morning. My topic is floppy iris syndrome. Floppy iris syndrome affects patients taking alpha adrenoreceptor antagonists. The incidence is 2% of, it affects 2% of cataract surgeries, and the incidence among alpha blocker users is ranging from 33% to 78%. And floppy iris syndrome is a triad of flaccid iris that bilos in response to fluid current, and there is tendency for the iris to prolapse through incision, and there is progressive meiosis. Tamsulosin blocks alpha 1A receptor, and it relaxes the smooth muscle of bladder neck. It relaxes iris dilator as well. This makes conventional dilator drops ineffective. Tamsulosin is not the only drug causing floppy iris syndrome. Other alpha blockers, some beta blockers, some antihypertensives, and some antipsychotics can cause floppy iris syndrome. In this video, you can see viscoelastics can be used as a barrier against floppy iris. The common complications of floppy iris are iris trauma, PCR, and vitreous loss. Pre-operative screening is important. You have to screen both male and female patients. Detailed drug history should be taken. If the post-mydriatic pupil size is less than 6 mm in a patient taking tamsulosin, floppy iris incidence is high. Long-term tamsulosin can cause atrophy of the iris dilator muscle, and this effect can last for years. So stopping tamsulosin before surgery may not be useful in all cases. To prevent iris prolapse, you have to make a triplanar incision. You have to make a slightly longer incision, and paracentesis should be small. This is to prevent iris prolapse through paracentesis. Trypan blue is used to visualize capsule during phaco. Trypan blue makes capsule less elastic so that you can easily do rhexis in a small pupil. Heavy viscoelastics reduce floppy iris. You can even do viscodilation with heavy viscoelastics. Coming to the most important technique, intracameral epinephrine, this improves iris tone by overcoming the adrenergic block. Dilute epinephrine with BSS in 1:3 ratio. Preservative-free epinephrine is used to eliminate endothelial toxicity. Adding epinephrine in the irrigation bottle is also useful in managing floppy iris syndrome. Episugarcane is a mixture of epinephrine, lidocaine, and BSS+. This is also helpful in managing these cases. In this video, you can see intracameral phenylephrine used to dilate pupil. Here it is used to facilitate cortical aspiration. Low fluid parameters will reduce turbulence in the AC, which will decrease billowing of the iris. In this video, neophysiological intraocular pressure is controlling floppy iris. You can see the IOP kept as 30, and even the aspiration flow rate are at higher level, maximum level. If you can keep IOP at a lower level, even higher other parameters may not affect you. Coming to iris retractors. In extreme cases of floppy iris, you can use iris retractors. Here there is no risk of mid-procedure meiosis, but you have to make extra incisions, and it increases the surgical time. The retractors may be arranged in a diamond configuration. That is, one retractor should be below the iris or very close to the below the tunnel or very close to the tunnel, so that it will prevent iris prolapse through tunnel. But rings may not be so ideal for floppy iris because it can get peripheral iris prolapse, and you may get some biloming of the iris. So to conclude, preoperative screening is the most important step. Increased lens thickness and decreased mydriatic pupil diameter were associated with increased risk of floppy iris. And intracameral epinephrine is the useful technique for the management of floppy iris. Thank you very much.
Thank you, Dr. Jason, for that excellent talk on IFIS, management of cataracts. Now let me invite Dr. Reshmi, a young surgeon, and she will talk to us on challenges faced by a beginner. Dr. Reshmi.
Good morning, all of you. First of all, I'd like to thank Jason sir and JP sir for giving me this opportunity. Here I will be talking about challenges in phaco for beginners. There are numerous challenges faced by a beginning phaco surgeon, especially if you are the only operating surgeon in the hospital. So, I would like to explain few challenges that I think will be beneficial for the beginner surgeons. So, I divided it into three parts: preoperative, intraoperative, and postoperative ones. The preoperative